Hi, I'm Mike, and I'm joined today with Chris, and we will be going over rotator cuff management and protocols. Specifically, small-medium protocol will be our point of discussion today. So we'll hit an introduction. That introduction will go over some general considerations conservatively, and then also as it relates to post-op management of small and medium tears. So our outline will be introduction, small and medium rotator cuff protocol, and then in a separate section, we will go over large and massive rotator cuff protocols. So by way of introduction, I should say over the years, there's been individuals, whether it be at church, whether it be at the gym, the grocery store, that you get to know either from the clinic by treating their hand or another body part, and I'm amazed at the number of individuals that have shoulder problems.
Yeah, probably almost everybody you look at has some degree of a shoulder problem, I would say.
And you often, the women tend to be more forthcoming about sharing their problem, typically, between 25 and 65 than guys are. Guys tend to show up a little bit later to the games, not because they don't have the problem, they're fessing up to it later on.
Yeah,
or
they don't say anything until it's a serious problem, yeah.
So, and then often they're asking for advice. And so a couple of the principles that we'll talk about at the beginning are general presentation. But if these things can be addressed early on, I believe in my experience, it changes the game so that perhaps the need for a surgical intervention becomes maybe not necessary at all if these things can be addressed. But sometimes, because they're not addressed, then the surgical intervention becomes a necessity in the patient's mind or in the surgeon's mind, and the patient has never got a chance to understand the conservative option and been patient enough to employ the conservative option. I think both of those things come into play. It does require some patience, and it does require some work.
Big emphasis on the patients.
Yes.
Especially for the athletes.
So, there's not a magic pill, though we wish that there were. For many patients, they think surgery is that pill, right? I'll have surgery, it'll cause the problem to go away, I'll be much better. Mm-hmm. And oftentimes, it may relieve some of the symptoms, but the problem that created those symptoms still persists in changes in the biomechanics that were poor to begin with.
Yeah, that motor pattern doesn't get adjusted or changed after surgery, so it's still a problem you have to look at.
Yes, yes. So some general principles to consider. Addressing pain, discomfort, tightness. Typically we see this on the anterior aspect of the shoulder repeat itself over and over. Long head of the biceps as a key player. Pec minor as a key player. And then this as a consequence of a deconditioned periscapular group and a deconditioned rotator cuff group. And so we experience, or the patient experiences, postural changes that have this cascading effect. Tends to shorten in the front and weaken in the back. They might go to therapy, or they might go to Surgeon X, and Surgeon X says, okay, you need to strengthen the rotator cuff. And they maybe do some external rotation, they do some work here in this same position. That same position often can cause them mechanical faults or frustration because those exercises, though good exercises, may be the wrong time because the pecs haven't been lengthened, long in the biceps has not been calmed down, posterior periscapular muscles have not been conditioned. So all it does is aggravate an already upset long head of the biceps and an already shortened pectoralis minor. And then the patient sometimes feels like therapy failed.
So you're putting a weakened area in a disadvantageous mechanical position and then asking it to do more.
Asking it to, it's exactly right. So we've talked about this as a capacity issue, right? So in that position, the rotator cuff doesn't have the capacity to handle any additional work. It irritates it, nor does long head the biceps or the pec minor. And so therapy fails. Well, that's part of the answer. Therapy did fail the patient because it was maybe good evidence-based therapy, but evidence-based therapy at the wrong time. And they need to address what would expand the capacity of that tissue to work. Open up the chest, strengthen the periscapular muscles. So the position of the patient and the presentation and the place of the tissue matters. And I think that's the skill of the therapist. If you can take that and contextually with the patient, then you can really move them from place X, where it's problematic, quickly to a new place. And that can become really rewarding. And we're seeing some patients right now where that's taking place.
Yeah, and I think that quickly becomes a big component of like education early, right? And just sticking to whatever way that you described that movement needed to be done, and just educating.
So there's a pattern of things beginning with weakness of or tightness and soreness of the anterior segment, and then weakness of the posterior segment. Long head of the biceps, we often talk about when the long head of the biceps tries to depress the head of the humerus during shoulder elevation. That's not its principal job. Biceps is responsible for supination, elbow flexion, and shoulder flexion. It can do all of those things. It can also kind of act as a pseudo rotator cuff and depressing the head of the humerus when the rotator cuff is deconditioned during shoulder elevation. So if we think about shoulder elevation, normally there's a force-coupled relationship between the deltoid and the rotator cuff. Well, the deltoid tends to be a really strong muscle. So if the rotator cuff is deconditioned, damaged, hurt, somehow its integrity changes, that deltoid is still strong, and so it pistons the head of the humerus superiorly. Long head of the biceps tries to depress it. This goes on repeatedly. Long head of the biceps gets tender. The more it goes along, the muscle belly gets tender. The longer it goes along even further, its insertion in the radial tuberosity becomes really painful. So anecdotally, if it's tender here, more acute here alone. If it's tender here and here, it's been there for a little while. If it's tender all three places, it's been there for a significant period of time and is aggravating. So a good part of what we need to do is undo this tenderness, because oftentimes this tenderness won't allow the patient to do any concentric work until it calms down.
I think a lot of times people get this pain here at the head of the bicep they get it really confused with deltoid pain. So a lot of times people start chasing anterior deltoid work and they're not really thinking about the rest of everything.
Yeah, good point. Okay, so we know that the proximal tendon of the long head of the biceps, it's richly innervated with sensory nerve fibers. The tendon is encased in a synovial sheath and is therefore intra-articular yet extra-synovial, as it courses obliquely through the joint and arches over the head of the humerus. As it arches over the head of the humerus, that's what allows it to be a depressor to the head of the humerus. And because it's so richly innervated, hence the pain. So if a patient goes in for a rotator cuff procedure, oftentimes they might just cut the long head of the biceps because it's such a problem. If it's mine, I want to hang on to it. I want to solve the mechanical fault. I don't want my biceps to become weaker than it needs to be. I want to try to address it. But sometimes if the patient doesn't get conservative care early on, then they go on to have a long head of the biceps release when they may not have necessarily needed that had they got care early on. As we kind of discussed offline earlier, there might be those older patients that are so advanced in their life and their demands are so low and their pain is so high that releasing or cutting long head of the biceps is at limited expense to them, and that the positiveness of the change in pain offsets any decrease in function or doesn't change function for them. It only enhances function because their limitations or what they're requiring of their shoulder is so small. We had mentioned the pectoralis minor. So pec minor is one of those areas where when it tends to shorten, it brings the shoulder forward or protracts the scapula. And when it protracts the scapula with a patient in a supine position, as you see here, it changes the height of the AC joint relative to the surface they're laying on. So if one side is tighter than the other, you're going to see a greater distance or greater measurement left to right or right to left, because the AC joint position has changed because pec minor has shortened. So the pectoralis minor, based on its attachments from the coracoid going to ribs 3, 4, and 5, is capable of producing scapular internal rotation, downward rotation, and anterior tilt. So when it shortens, it anteriorly tilts. Has a tendency to downwardly rotate and then also depress that scapula. Questions, thoughts to this point?
Oh, I did have one. I know that there's been research out there, and I'm sure somebody's asked you this. There's hearsay about posture, since we're on the topic of posture, being more of a genetic component than actually a component of how that person moves on their own. Basically saying that if you're someone who sits like this, it's not the posture that's attributing to your shoulder pain, it's more genetic than posture. What say you about that question? It's kind of a weird one.
Well, there can be a genetic component to that. Probably a genetic component that needs to be changed.
It's like structural differences.
Right.
Yeah.
But there's probably some changes that still can take place. There may be some patterns that make it more also familial or genetic and then also learned. If it's a scoliosis type of situation or a kyphotic posture, things that are skeletal related genetically, then that becomes maybe a different issue, right? Or one that should be considered. But assuming that those are correctable, then we should be able to get them back in order here.
And everything should be correctable at least to some degree.
To some extent.
Right.
Unless you're having like a scoliosis type of situation or a kyphosis where the limitations are not correctable with exercise alone. Some of those are, right? So some of those patients that have scoliosis, giving them a set of exercises and they can keep that scoliosis in check, if not, kind of correct part of it.
These would be those younger people.
Yes.
Right? Yeah.
And then there are other cases that are more severe where it's not.
Once we start to have so much breakdown or arthritic symptoms that we start getting fusion of, say, like lumbar and thoracic, then
Right.
it becomes more of a problem.
Right.
Makes sense.
Or a greater curvature. So an excess of active or passive tension in the pectoralis minor muscle could subsequently resist normal scapular upward rotation, posterior tilt, and potentially scapular external rotation that should occur during elevation. So what we're suggesting is during shoulder elevation, normal shoulder elevation, we should see upward rotation, we should see a posterior tilted scapula that externally rotates. Well, when pec minor is tight, it resists all three of those. It resists posterior tilt, external rotation, and upward rotation. So it's an antagonist of those muscles. It resists, thus limiting shoulder elevation and contributing to a closing down of the subacromial space. So when healthy subjects were categorized as having a short versus a long pec minor resting leg, those with a short pectoralis minor had muscle tightness that demonstrated significantly less scapular posterior tilt, greater scapular internal rotation during arm elevation because of the resistance of pec minor. So pec minor and long head the biceps conservatively in this population or post-operatively are major contributors. So if we take a patient like this, so she's doing a push-up plus or trying to do a push-up plus, the point we want to make here is that when we have a restraint against scapular movement, it creates changes. In her case, she has significant weakness of serratus. We see the winging, significant weakness of subscapularis of her cuff in general, and tightness or shortening of her pectoralis minor. But pectoralis minor isn't the only cause of this. It's a contributing factor to this. So as we look at a patient like her, ask them to do a push-up plus type of exercise, we begin to create this list of things that need to change kinematically. keeping in mind that these are related to one another. It's not just one thing. And I think that's what makes the puzzle of scapular dyskinesis or scapular pathology and rotator cuff a really entertaining one to treat and a challenging one to treat, because it's very case specific to the individual, what they can, what they're willing to do over a course of time, and keeping a buy-in so that they stay with the program long enough to where they can appreciate success. All right, so we've talked about the importance of scapular positioning. So reductions in scapular upward rotation and posterior tilt during arm elevation could reduce the available subacromial space, as we mentioned, thus contributing to the development or the progression of impingement, as well as a poorer environment for tissue healing. So the poorer environment for tissue healing has everything to do with this subject of rotator cuff management. So if you think about the position of the scapula, the head of the humerus sets in the ball part of it, right? The glenoid. Well, the position of the glenoid changes relative to the tilt of the scapula, right? Mm-hmm. So the position of the glenoid, hence the position of the head of the humerus, hence the origin and insertion relationship of the rotator cuff changes as a result of the tilt of the scapula. So as it tilts anteriorly, the scapular tilts anteriorly, it closes down the subacromial space, but also makes it more difficult for the rotator cuff to operate efficiently, thus creating a disadvantageous environment for a cuff to heal if it's a small tear, or conservative management to take place during like an irritation of the rotator cuff or a fraying of the rotator cuff.
Which is why we go straight towards retraction and depression as early as we can.
Exactly. So oftentimes that's overlooked. You might get a referral that says rotator cuff strengthening. That's all the referral says. And the therapist says, okay, all right, so let's get a band, let's do standing external, internal rotation, let's do some full can. And they're doing what the order said. And they're doing the right thing, but they're doing the right thing at the wrong time.
There's a missing piece.
There's a missing piece, and that is the scapular position. So it's incumbent on the therapist to understand scapular kinematics, shoulder kinematics, for them to effectively prescribe rotator cuff exercise.
So you think this is something that is commonly kind of, like pieces are commonly overlooked?
100%, yes, 100%, right. And you also see patients that go to the orthopedic surgeon. You have a weak rotator cuff. Hey, let me just give you 3 exercises, and then you're on your way. Patient gets the exercises, and they come back after 4 weeks, and they're like, oh, it's worse, or it's no better. And they're in that cycle. And not only are you doing the wrong thing at the wrong time, but you're wasting their time. And you're wasting healthcare dollars. And you're wasting their frustration level, their tolerance for healthcare, right?
Yeah.
So they're like, I've already been at this for 8 weeks, and plus, by the time they get to you, Chris, as a person who knows what they're talking about, they're exhausted with the process. And maybe they have a couple visits left in them, but then they want to peter out. And so for you, you're following what has been a series of bad decisions, trying to get them to subscribe to you when they have questionable investment.
Yeah, that becomes a tall order for whoever's second, right?
Becomes a tall order. And so your ability to work quickly is imperative. And so one of the things that I think is the answer for that, a little bit of a sidebar from our discussion here, is the soft tissue work, right? So when you get in on pec and you work it, you get on subscap and you work it, now you get buy-in from them. In addition to their exercise, because they're feeling better, and they're like, okay, when I go to Chris, he works me out, he's giving me some exercise, he's watching me, he's helping me progress. But that soft tissue, I think, is a really underprescribed, underutilized skill set to help the patient change their tissue, but maybe more importantly, or equally as importantly, allow time for them to buy into the exercises that they need to do.
The window of opportunity, as I like to refer to it as.
Yeah.
I think that, and to second, somebody there watching you.
Yes.
Right? it takes a lot more than one repetition correct for that to stay correct.
Correct. So yeah, great point. So if we're looking at periscapular work, the point that we're driving home here is that the periscapular function is imperative for the rotator cuff to operate efficiently and effectively. Okay, and we've covered each of these segments. So to try to encapsulate this in one slide, this slide I've used on many presentations. It's one of my favorite slides just because I think that many of the problems associated with conservative management of rotator cuff challenges, post-operative management of small to medium tears or large to massive tears, reduces to what's on this slide.
That's a good slide.
And that is anteriorly pec minor and long head of the biceps need to be undone and they need to be lengthened. Rotator cuff needs to be strengthened. Serratus, low trap, and middle trap need to be strengthened. Upper trap, levator, and deltoid need to be calmed down. Now, how you do that, that's the amazing part of what the therapist should do, right? So getting them out of compensatory patterns, calming it down, and how you do that, some of it you can do simultaneously. Sometimes you need to just undo the pain before you can begin to address any of the conditioning. And so I think this slide you can apply to so many different patient scenarios and prioritize based on the presentation of the patient. But you're chasing these principles.
Yeah, I think it summed up very well.
Okay, so additionally, general principles to consider: the integrity of the rotator cuff tissue, the posture of the scapula, the overall posture. So their pelvic position having an influence on thoracic extension and vice versa, or thoracic flexion, shortness or tightness of the biceps, and also pec minor, tenderness of the long head of the biceps, and then the ability to progress non-provocative periscapular and rotator cuff exercise. And the operative word here is non-provocative. So isometric walkouts may be part of that, as we'll kind of detail in further slides, but finding a way to help them condition those structures that are weak. And that can be sometimes a tall order, particularly if you're doing soft tissue, because the patient may only want soft tissue. Because that feels good and it's passive, they don't have to do anything.
Yeah.
And they're less inclined to want to do exercise. And then also worth considering the 3 different types of muscle contracture as it relates to conditioning or strengthening. Isometric, where we're thinking about controlling movement, stabilizing or stopping movement. Eccentric, where we're modifying or slowing down movement, and then concentric, where we have a contraction and a movement of the joint angle. And each of these have a different place in the rehab process. So small to medium rotator cuff repair, we'll get into the protocol. So this protocol is the protocol for the University of Florida Orthopedic Center for the Division of Hand and Upper Extremity. So we're considering the rotator cuff size, type of repair, tissue quality, the number of tendons that are involved, and then the patient's presentation. Does the patient have diabetes? Do they have other comorbidities? What is their body mass index? Are there other things in their age that might be factors? So we need to take the patient in context. So rotator cuff, small to medium, this would be those tears that are 1 to 3 centimeters in size. The goals to maintain integrity of the repair: gradual increase in passive range of motion, gradual increase in shoulder strength, and decreased pain and inflammation. Phase 1 would be 0 to 6 weeks. In phase 1, 0 to 6 weeks, we have precautions: no lifting of objects, no excessive shoulder extension, stretching, or sudden movements, no supporting of body weight or operative hand or arm movements. So we'll often have a discussion with patients in this phase and the importance of avoiding activities. They may be doing exactly what we tell them in terms of exercise, and not avoiding these things or disregarding the precautions, and that becomes a very frustrating thing. They're doing the right thing, but they're doing all the wrong things as well, and that becomes a vicious cycle of failure. So we've got to get it in their mind the importance of not doing these things. I've seen many patients who avoided the wrong things and didn't do their exercise, and they did pretty well. And lots of people who did the exercises and did all the wrong things, and they're very frustrated. So we can't underscore enough the importance of avoiding those things that are provocative. So this would be a quick timeline. The protective phase, which is phase 1, 0 to 6 weeks. The intermediate phase, phase 2, 7 to 12 weeks. The advanced strengthening phase, this is phase 3, 13 to 20 weeks. And then phase 4, 21 to 26, this is return to activity. So in phase 1, 0 to 6 weeks, 0 to 2 weeks, the sling or brace will be on for 6 weeks. Perform elbow, hand, wrist, range of motion exercises, modalities to control pain as necessary, pendulum exercises each day, no passive range of motion other than pendulum exercises. And the pendulum exercise, you want the arm to be an extension of the body. The body is what moves and propels the arm, not the arm propelling itself actively. And then also in the protective phase, 0 to 6 weeks, if we're talking about weeks 3 through 4, we start passive range of motion to tolerance, flexion with the goal of 90 degrees but limited due to pain, external rotation and internal rotation in the scapular plane, encourage safe home exercise program. And then in this, the image kind of notes flexing the elbow passively and then bringing them into shoulder elevation. So we've shortened the lever arm, decreasing any work that the patient is doing at the shoulder. And I think that part is a nice key. It's more helpful for the person who is the therapist or the provider of the care because they are handling less weight. And also it's easier for the patient and takes any co-contraction or active recruitment of the shoulder muscles out of play. 5 to 6 weeks, we continue passive range of motion, gentle stretching with the goal of full passive motion as pain allows, flexion to 145, external internal rotation to 45 in the scapular plane. Active assistive begins about 6 weeks, flexion to about 120, internal and external rotation in the scapular plane. You come out about 30 degrees or so, get 30 degrees as you approach 90 degrees of abduction. Featured here in the small video would be the box exercise where the patient has a dowel and they're able to actively, with the use of the dowel, which would be a true active assistive motion, complete a box motion. So it allows them some bent elbow shoulder flexion, allows them to bring that away from their body with elbow extension, isometrically holding their shoulder, eccentrically loading their shoulder, concentrically retracting. So this box exercise is a nice way of incorporating the different types of muscle contraction in an active assistive way. Worth noting here is an article, JOSPT, shoulder EMG measurements during activities of daily living and routine rehab exercises. So featured here on the top would be the muscle, supraspinatus, infraspinatus, teres minor, subscapularis, middle deltoid, biceps brachii, upper trapezius. What we're looking at is the individual activity. So shoulder elevation with a dowel, pendulum exercises, fingers connected, shoulder elevation like this. General passive range of motion of the shoulder, sling donning and doffing, the pulleys, ambulation, pulleys in the sagittal plane, shirt don and doffing, and we looked at the they looked at the EMG values. And what we see here is high activation of supraspinatus with don and off of the sling, don and off of clothing, and walking. And so these are things that happen every day. So helping the patient become cognizant of the recruitment of these muscles and helping them change the way that they do it will help them decrease the pain, help them be more successful. And we see the same pattern through infraspinatus, teres minor, and subscapularis. And then the role of upper trap high in many of these activities because of its compensatory pattern. So we see it graphed differently here. Supraspinatus, infraspinatus, teres minor, subscapularis, deltoid, biceps, upper trapezius. Noted in the green would be the shirt, don and doff, sling in the orange, and then pendulum in the blue. So we can see for supraspinatus, infraspinatus, and teres minor and subscapularis, or the rotator cuff muscles, when you do pendulum exercises, very little activation compared to taking your sling on and off, the very thing that's protecting you. So instructing them how to do that properly so that it minimizes the involvement of the cuff becomes really important. And we see that with different activities here, ambulation, the pulleys in the sagittal plane, and then pulleys in the scapular plane. And we see the same patterns arise here. So the goal is to familiarize, educate the patient to the activities that they need to do and help them modify those or limit the donning and doffing of the sling so that you minimize the involvement of the cuff. So the goals in phase 2, full non-painful active and passive range of motion by week 12, gradual improvement of strength and power, gradual return to light functional activities, encourage safe exercise program, and that's from 7 to 12 weeks. Here we demonstrated in the left, we have the same principle of shortening the lever arm here in an active situation where we're asking the patient to drive those elbows to the wall in front of them in place of bringing their arm up like this. So we're asking them to initiate the movement and drive the elbow in front. It changes the pattern entirely from a compensatory pattern to one where the shoulders tend to stay with the upper traps neutralized, and then from here we can extend the shoulder or extend the arm. So here we see that highlighted. Any comments, thoughts here?
For whatever reason, it seems to allow the middle and the lower trapezius to work more effectively without the involvement of the upper trap, and then by the time you get to extending your elbows, you're already in a position where you don't really need your upper trap. It's actually pretty cool.
And we have a patient right now with proximal humeral fracture, now about 10 or 12 weeks, where we really, I wish we had the video of him doing this, but it's markedly different.
Oh, yeah.
And you train them to function that way. And then they appreciate good kinematics, and then they can show advancements at a greater rate. But as soon as that shoulder goes to hike, all bets are off, right? So you're recruiting the wrong muscles. We have too much activation of upper trap and levator, and we have less activation of low trap and middle trap. So the wrong ones are being engaged, and the ones we want are never get a chance to go to the party.
Now, what are your thoughts on that being, I mean, you already kind of noted to it, but a lot of that is because that upper trap is so much stronger comparatively that the other two don't really stand a chance to combat that,
Yeah.
right?
So this helps to alleviate that. You might put them in a gravity eliminated position to help alleviate that. But it's hard for them to shut that out. But this exercise, for reasons that may be known to us in part and maybe known to us or less known to us, when we ask them to do this cognitively, motor pattern is different from the neuromuscular pattern that they're used to doing when they elevate their arm in a normal fashion seems to change.
Well, the requirements, I believe, are somewhat different too, right?
Yeah,
that might be why.
Because we're asking them, the instructions are point your elbow to the wall, not lift your arm. So these are the instructions. So the patient is thinking elbow here, move elbow to here, which is every bit of shoulder movement, nothing of elbow movement, right? But there's something about that changes that we need to further understand.
Yeah, I mean, is it just the fact that the lever arm's in a different position?
I think that's part of it.
Right.
I think that's part of it. You shorten the lever arm, that certainly helps. But I think that there's something about the deactivation or the inhibition of the upper traps in the ask
Just inherently
that
happens. Yeah.
that begins the movement differently, and we need to better understand that.
Yeah. It works. All we know right now.
So continuing phase 2, weeks 7 through 10, we discontinue the brace of the sling, maintain full passive motion, and progress to active assistive. This would be inflection per tolerance, external internal rotation to tolerance, and then external internal rotation at 90 degrees to tolerance. And here we see the box activity. So 2 students here in the studio, and then our student Dayton, he is sporting the stringer. And he does have a role here other than just to look good. He does participate, but not as well as Savannah does the exercise. So, yeah, his is a stand-in role here.
I see why he's wearing the pants. There's a disparity.
Yeah. Okay, so phase 2, weeks 7 through 10, strengthening. Start at week 7. You can use external rotation, tubing or TheraBand, prone rolls and neutral, prone horizontal extension or prone horizontal abduction, bicep curls. Shown here would be side-lying external rotation against gravity. But we're beginning to help pattern the patient so they understand the movement. We can begin to condition it with good body mechanics before we add a load. It's a fine time to begin isometrics. Here, we're manually doing those isometrics. You can have a handheld dynamometer that will give you value as well. But this becomes a really nice way for you as a patient or you as a therapist to work with the patient hand in hand, and you get an idea proprioceptively how well they understand and able to resist. So it's a favorite way to get submaximum contraction, a favorite way to get maximum contraction isometrically, and to prepare and condition the muscle for what would be eccentric and concentric work. So this strengthening weeks 8 through 9. And then still in phase 2, weeks 10 to 12, maintaining that maintaining full active and active assistive motion and strengthening. Shown here on the left would be an external rotation walkout where there is no external rotation movement. The resistance of the band provides the isometric resistance. Rhythmic stabilization, isotonics, all would be appropriate during this phase. Moving on to phase 3 or the advanced strengthening, this would be weeks 13 through 20. The goal is to maintain full, non-painful range of motion, improve shoulder complex strength and neuromuscular control, hence the body blade. So the body blade becomes a great way where the patient can learn to initiate stabilization of the periscapular muscles and contraction of the rotator cuff muscles. If you don't have that, you can't do it. You try to move the body blade, it becomes this gross motion, and you can never create those oscillating movements. So a great way to begin advanced strengthening in a neuromuscular fashion. And we'll see that pattern throughout, that as the patient gains neuromuscular awareness or proprioceptive awareness, their ability to regulate that shoulder in space and with activities is improved. Week 13 through 16, we're maintaining all the range of motions. We're initiating different stretches. We're shown here like a Theragun to keep length of those muscles. Patients can self-modulate with this and self-administer in such a way that they're keeping those muscles at length, limiting trigger points that could ensue and are building up as they're adding conditioning to what they're doing. So we're always trying to be cognizant of what the tissue is and how we need to change the tissue so it can perform, so it can take on an external load. Is the internal tissue healthy enough that it can take on an external load? How much of an external load? And we're progressing it from No external load to the weight of the extremity assisted, to the weight of the extremity not assisted, to the weight of the extremity with a load or bearing weight. So that becomes the name of the game. So in week 16 through 20, we may advance them to a push-up plus, as we see here. This can highlight some disparities in some weaknesses and help us to figure out what we need to address. So in this case, weakness of serratus and subscap, perhaps still tightness of pec minor. Begin plyometric exercises also at this phase. There may be tightness of latissimus dorsi, so as or teres major too, as they are tight, going from the pelvis all the way up to the arm, that can limit terminal shoulder elevation. So as the patient gets stronger and able to do more, it's important that we're always thinking about the tissue and that we're bringing the tissue to added length so that they get range of motion, full range of motion, and they can have power through that full range of motion. Not a limited range of motion and strengthen that limited range of motion. That only is a recipe for disaster and the likelihood or increase in likelihood that they'll return to therapy. So in phase 4, 21 to 28 weeks, maintain shoulder range of motion, strength, neuromuscular control, gradual return to their sport or their strenuous occupational activities. In weeks 21 to 24, we have shown here again isometrics because I think as they're advancing, it's important to stay on their ability to stabilize. Oftentimes as they go through concentric work, they're doing that through their sport or through their activity. And so the ability to come back to the isometric as a home base or as a common thread throughout, I think is a great way to help them to maintain the health of their tissue and not have them circle back. Any thoughts here?
I think there's value for it. Maybe not throughout that whole thing, but definitely worth coming back to see how that person tests, because I think it's going to be a very good indicator if something is missing. And then if it is, that's where you can kind of start to adjust ranges of motion in an isometric contraction or change the way that they're loading it in maybe a more challenging position as opposed to where they began at 50% range, for example.
Good point. So if you're taking handheld measurements early on, you'll have this as those as a baseline of comparison at whatever later date.
Yes.
Still in phase 4, working on that flexibility. In this video, we're looking at shoulder external rotation with the arm abducted. So this creating an additional strain on the cuff and a more advanced movement. So that would be the last slide on the small to medium. So the common theme is we're preparing the tissue to take on an additional external load. We're preparing the tissue anteriorly to have more length and become less tender and painful. We're preparing the posterior tissue to become stronger without trigger points, without areas of restriction, so that it can perform kinematically and hold the scapula in the right position so that the cuff, the glenoid, can be in the right position and the cuff can be efficient. That's what it reduces to. Any concluding thoughts?
I really like this protocol. It leaves it very open-ended in terms of these are the things that we want to see, but it allows you to kind of decide how you want to get to those.
Yes.
So it keeps you on track without doing something you shouldn't do, but also gives you a lot of leeway to figure out how you're going to achieve that goal in that time frame or phase.
Yeah. I think having the tissue healing part and understanding that is the common thread that allows you that flexibility. All right, so that concludes this segment on rotator cuff management and protocol, the small to medium repair, and a bit of the conservative care.